Welcome to this series of interviews with the giants of cardiac surgery. My name's Joel Dunning, and I'm here at EACTS in Vienna with one of the giants of cardiac surgery, Professor Friedrich Mohr. Thank you very much for coming to talk to us. Well, I can hardly believe the number of things you've done in your career. You're Professor of Cardiac Surgery at the Heart Center in Leipzig, and you've been Professor of Cardiovascular Surgery in Göttingen. You set up Leipzig, which I think a lot of people now regard as the world's greatest cardiac surgery center. You're International Director of the Society of Thoracic Surgeons. You've been President of the Society of Thoracic and Cardiovascular Surgery, past President of the Society of Heart Valve Disease, and just coming up now, you're also going to be editing an excellent edition of the Annals of Cardiothoracic Surgery, where you're going to present a whole load of articles and videos completely free for the community of the world, which is fantastic. But before we talk about minimally invasive mitral surgery, I wonder if we could just talk a little bit about the early days. I understand you went to the University of Berlin, Bonn and Sydney, but it was really in Poland that you saw your first heart surgery operation. What did you watch, and what was that like?
Actually, I was at that time a medical student at the University of Berlin, and I went for an elective to Gdansk, which was very interesting because nobody spoke German or English or French. We talked to each other in Latin. And I was with medical students and appointed to the Department of Cardiovascular Surgery. And then the story was told, the first open heart will be done in Gdansk, whether I want to see that. And I said, okay, I have to go there. And the biggest surprise for me was that all in a sudden a wonderful blonde surgeon, a lady, Professor Narkiewicz, entered the room. I think she was in the early 40s or even a little bit younger, was trained in Rotterdam, and she performed the ASD closure. And I thought, Jesus Christ, if this woman is so beautiful and she can do it, this must be the way of your lifetime. And so I followed the track of cardiac surgery. And there was an interesting event. Many years later, I was invited by the European Society of Cardiology in Katowice, and I told the story. And this is maybe 20 years ago when I started at Leipzig. All of a sudden, she got up in the back room. Oh, this was me. And she's still alive. She is in the mid of 80s right now, and she was the grand lady of cardiac surgery in Poland.
Fantastic. And after that, you did your cardiovascular surgery in Bonn, and then you went to America, Cedars-Sinai. And one thing that's impressed us all about your career is your ability to mix cardiology and cardiac surgery. You did some thermal coronary angiography and some laser angioplasty. And is that really where it started, your ability to bridge that cardiology-cardiac surgery gap?
Actually, I was a fellow assigned to both departments, the Department of Cardiology of Dr. Swan, so I was a cardiology fellow, and I learned to do cath lab procedures myself, and I performed in animals excimer laser angioplasty and in peripheral arteries, and I was quite good at it. And the idea was to measure these temperatures during laser angioplasty using thermal cameras. And at that moment, when I injected some dye into the coronaries, I realized that the coronary anatomy was perfectly delineated by the temperature difference, like in an angiogram. And I talked to the cardiac surgeon, who was Jack Metloff, the chief at that time. I said, Jack, this is something we need to try out in open bypass surgery to control our patencies. And so I did. I took the camera every day into the aura, and we checked it, and we did find a 4% failure rate, especially at the posterior wall, and was, I think, was a very ingenious technique. And for example, in our center in Leipzig, we had implemented that in all 6 hours when I started that in 2004.
Yeah. Do you think we should check all our patencies?
I always check, either by transit time flow measurement or by epicardial echo. I do it myself, and I ask all my residents and coast surgeons to do so as well.
Yeah, yeah, that's amazing. One other little thing I read, you went back to work in Bonn, and then for holidays, taking a holiday, you used to go and watch surgery in Texas.
Yeah,
what did you go and watch?
This is, I was fascinated by Denton Cooley and Stanley Crawford, the way they made cardiac surgery easy. My boss was trained in Göttingen, and everything was so complicated. And when I went there and watched how, by just simple tricks, they made things easy and quick, I think I have learned a lot how to simplify and change things in Houston, and that's why I went back and forth. My girlfriend or wife didn't like it so much because half of my holidays was spent for checking these guys out in Texas.
Yeah. So tell us about how your association with Leipzig started. How did that all begin?
At that time I was a professor in cardiovascular surgery in Göttingen, and as everybody, if you turn into the 40s, you think, it's time to apply for your own department. And I have applied at the same time in Frankfurt and in Leipzig, and I was also appointed at the same time at both universities. But in Leipzig it was a unique model because it was a private company who built a brand new hospital. It was in East Germany. Everybody told me, you are completely crazy to go to East Germany. But I knew from the numbers that 18 million people in East Germany, they almost didn't have cardiac surgery, only 2,000 operations per year. So there was a unique chance to grow something like, I thought you could do something like Texas Heart over there. And this was my gut feeling, and that's why I made that decision, and I never regret it.
Sounds like you got it right.
Yeah.
So I think you performed the first robotic mitral operation. Tell us how that came about.
I was early involved in the minimal invasive work, and I went to Stanford to train the hardcore techniques and the endoscopic work. And at that time we came across the intuitive robotic system in 1996, and I sent one of my co-workers, Volkmar Falk, to Stanford to spend a year with Intuitive together with Didier Loumet. They explored the techniques, how we can perform, and Carpentier and myself, we were the two ones who started these operations 1 week after the other. So I've been in Paris when he did it, and he came to our place. So this was everything happening within 10 days. And at that time, I was fascinated about that technology, a real step forward, 3D vision, and the tactile improvement. And compared to endoscopic techniques, it really brought us a real step forward. We stopped though in 2002 because we had learned meanwhile how to do the mitral valve without robotic assistance, maybe the same or even better. And of course, it's always a matter of cost.
Yeah, so you did move away, from robotic, and you've done over 3,500 VATS mitrals in Leipzig, of which I think you've done about half. And
that's true, yeah.
So let's move on to a little bit about the minimally invasive mitral. But and just first of all, if there's people watching this that do a lot of open mitrals, what do you think the best way to move across to a minimally invasive technique is? How should somebody get started?
I think there are two things to it. First, you need to understand mitral valve disease, and I've learned that through Carpentier's courses as a young resident. And you have to understand the acute pathology of the patient by carefully looking at echo and maybe MRI to have a real good picture prior to surgery, and make up your mind, this is going to be my strategy of repair. This has to be set up before you look at the valve at all. And if you can do that, you may decide, okay, this one I can do endoscopically, or this one I do in open sternotomy. And if you do it in open sternotomy, this is my advice, you should start using these long-shafted instruments, because it's a different way how you move the instruments. You just turn your fingers. It's not like this. It's like in coronary bypass surgery, very fine stitches, different technique. And this is something you have to get used to. And the best thing, of course, is to start in open cases and then get it down to the small incisions and do it through the monitor.
So are there still mitral cases you do open?
Myself, no. Even the severe calcification I take out in the Carpentier technique and I patch it. Yeah. But my colleagues still do some cases. We do about 500 minimal invasive and 100 sternotomy cases a year.
And would you say your general repair techniques are Carpentier based rather than moving towards sort of caudal sort of repair and preserving a little bit?
Yeah, I think we moved a little bit away from Carpentier's strict resection techniques. We respect the leaflets. We sometimes partially do a triangular resection, and we use a lot of caudal replacement to support the leaflets and preserve them.
Yeah.
Even if I resect, I would use a cord to support the pathology.
Yeah, and I suppose it's a bit easier, isn't it, a little bit when you're doing an endoscopic. And just a few things about, cannulation. Do you do percutaneous, or do you still not find that
Actually, we do some percutaneous for many aortic cases. We do the percutaneous venous approach always. For the mitral valve, we still expose both vessels. Maybe it's wrong. We could do with these closure devices also a percutaneous.
You can stop it bleeding a bit easier when it's open, can't you? Yeah. And do you still use an SVC cannula or less and less?
It depends on the patient. If it is a heavyweight patient, more than 100 kilograms, he will have an SVC cannula, and all patients who have a tricuspid valve in addition.
Yeah, of course, yeah. And I suppose one thing that people might find sort of anxious when they're starting VATS is getting a good view of the mitral valve itself. What would you say might be the key, sort of the keys to getting that good view in minimal access mitral?
I think it's exposure. Exposure is the most important thing. You need to take your time and in size at the right level for the intercostal space, put the camera at the right side, and take as much time as necessary to really have a nice exposure, and then you can start working, even if it takes 10 minutes. Otherwise, if you don't do that, you lose the time and everything is messy. I think this completely step-by-step exposition is the important step. There are some tricks to it, but some special retractors you can use, like Hugo van Neumann has developed a special retractor, which I think is a nice thing. We have a different kind of lung retractor which we may attach to push down the posterior wall. But I think you should not start the procedure without optimal exposure.
Yeah. And what do you like best? Do you like an endo balloon or a clamp, or what's your favourite?
The clamp. Actually, the clamp. The endo balloon I have been using, I don't know, in 500 cases, and we did have kind of an incidence of it, higher incidence of neurological problems, because the de-airing was kind of more difficult, and also sometimes the balloon migrated to the arch and occluded the aortic arch vessels, which we didn't realize. And maybe the balloon is better now. We just use it for redos now.
Yeah. Have you ever tried beating heart port access mitral?
Actually, in patients who have reoperations and they have a competent aortic valve and open bypass grafts, we do a beating heart or fibrillating heart. It depends how complex the case is. If it's a very complex repair, I think you are better off and even go for sternotomy to arrest the heart, because if it's beating and the stitches are not secure in the annulus, you may end up with a ring dehiscence. So it's something you don't need.
Yeah, And something I struggle with is sort of severe MR with the really severe heart failure patients. Do you do that? Do you do mitral undersizing, or how do you treat those?
Actually, we evaluate these patients very carefully, both by echo and by MRI, and it depends on the restriction. You know, if it's too much of a restriction, we would go ahead and put a mitral, biological mitral valve on top to be safe. We do not undersize too much. We use these ischemic rings from different companies and downsize a little, but we don't do the downsizing to 26 or 24. Then we rather would go for a mitral valve replacement.
But is any ventricle too bad to operate on?
I think if you look back into the data, I like to have on these patients a stress test. So if they have either dobutamine echo or MRI, and there is no positive reaction, usually these patients don't recover if you do something on the mitral valve. And I think twice, if these are ischemic cardiomyopathies and there is no positive reaction, you may close the valve and end up in severe cardiac output. So would be very careful and would consider, if possible, and the anatomy would allow it, an EVAF procedure nowadays.
Yeah, and how liberal are you with tricuspid repair? Is it
very
even
liberal?
moderates? And,
I mean, every patient who has concomitant tricuspid regurgitation has a tricuspid repair. We measure the annulus. If the annulus exceeds 40 millimeters, it's going to have a partial ring.
Yeah. Even if it's moderate or even a bit mild to moderate, because of the annulus. Yeah. And what do you do about atrial fibrillation? Somebody, a bit of paroxysmal atrial fibrillation, but sinus rhythm in theatre?
We'll have an ablation. For many years, since 1996, we have been using radiofrequency first. After we had some esophageal problems, we have switched almost completely to cryoablation, and we would include this as a strategy for the mitral valve repair, and also take care of paroxysmal.
Yeah, great. And do you close the appendage in everybody, even sinus rhythm patients? Or?
Oh, that's a very good question. It's something I learned through Techno College the day before yesterday. I used to, if the left atrium is extended and large, we would close it from inside. And I have seen Thomas Kunze here in the live case where he used from the right side through the sinus thrombosis, and he put a kind of clip system from Atricure on the atrium. And I think that's a great idea. I haven't done that, but I that's one lesson I learned through the Techno College, and I will do it on all my patients now, because from the inside you can capture the circumflex artery easily without knowing, and then you are in cardiac low output and you have to redo the things, and so I think that's a good step forward.
Yeah, great. So maybe just moving to a few other little things. You've done so much. I've got to talk about a few others. And I think you did one of the world's first robotic coronary artery bypass operations. Obviously, we don't do that so much now. But and you've done research on arterial grafting and imaging. But so, what do you think the best operation for triple vessel disease in a 67-year-old good LV? What would be the best operation? How was that robotic bypass graft?
I mean, the robotic bypass graft was extremely good for taking down the IMA grafts, and was also, in my eyes, very safe as long as we arrested the heart with the hardboard technique. So we could do 1 or 2 IMA grafts in the same patient in an arrested heart. As soon as we started with these kind of stabilizers, it was an insecure operation. And the attempt with different anastomotic devices all failed more or less. You know, if you think about Ventrica, this magnetic device, we thought it's wonderful, but somehow the patency didn't prove to be sufficient. The beating heart robotic work for us at the very end, we thought it's too complicated. There are some heroes still who do it, like Bonatti or But in our hands, we thought we go back to the mid-cap procedure, and in a 67-year-old man who has triple vessel disease, I would go for full sternotomy, use both IMAs, and do an off-pump procedure with Y grafting. And then this is one of my favorite surgeries. Used to be one of my favorite surgeries.
Yeah, and obviously, as well as operating, you've done some of the greatest recent trials. You led the surgical arms of the Syntax trial, and Excel's ongoing. And what have you seen change from Syntax, and what do you think Excel might teach us?
First, I think the Syntax trial was a great trial because many very well-known cardiologists and cardiac surgeons came together, and for many years they didn't talk to each other, and we talked to each other, and we always found a consensus, and we wanted to find out what is really true, and we wanted to define the complexity of the coronary artery disease itself by the Syntax score, and whether the Syntax score will have an impact on outcome, and also, of course, find out who are the patients who are better treated this or that way. And the results, since we touched very complex patients, as you know, are in favor of surgery, especially if it's getting to be very complex, which might have been expected by some experienced cardiologists because of multiple stenting using 8 stents, etc. One could foresee the stent rethrombosis and stenting. I was surprised with the results of the left main. There's a subgroup of the Syntax that we did have quite a number of, even though there were only a few patients, quite a number of complications in the surgical cohort. I didn't expect that many. As soon as the left main was getting complex together with 3 vessel disease, surgery again was superior. And that finally led to the situation that we needed to define the new trial. The Excel trial, which looks at left main with low Syntax and intermediate Syntax scores. Excuse me. I think this trial is very important because in Syntax, the left main was not powered for a statistical analysis, so it is just hypothesis generating all the conclusions from there, even though the cardiologists always say, from Syntax we know we can do it, this and that, which is not true. It's only hypothesis generating, and we need to have this randomized trial with the Excel to find out how that looks like. At 3 years, primary endpoint is mortality. I don't know. I would think it's going to be hard for surgeons.
Mm-hmm. Although it's a small part of our practice, perhaps.
It's a small part, though, yeah.
And we have plenty of other things to do. And I can't really talk to you without talking about TAVI. And so, but just perhaps one question. I mean, where is TAVI going to go next? Do you think we can do a transapical intervention on the mitral? Or where do you think the next steps are for TAVI? And what will you be doing in Leipzig?
I think we are prepared to do transapical mitrals now. Yeah. And there are about 10 companies working on this field, and I think for those patients who do have functional MR, it may be quite a good solution, maybe better than the current clipping and better than our surgical approach.
What sort of intervention?
Right now everybody focuses on transapical mitral valve replacement. And I think if this will come within the next 12 months. And so we should get it into our hands.
Yeah. What about the neocaudal sort of placement? Have you tried that?
My co-worker, Jörg Seeburger, is actively involved in that study and has some very good cases. You need to highly select those patients who have a very specified prolapse, not too large, and no annular dilatation, then it might work.
But it's going to come.
it's going to come. Yeah.
So just rounding off, I mean, Leipzig is this phenomenal place. It employs 1,400 people, 20 senior surgeons, 60 trainees, and they do 6,000 operations a year. And I counted some courses going on this year. There are 23 going on in your centre at least. I probably didn't count all of them. And I know for a fact there'll be people watching this wondering, you know, how can I either come to the centre or interact with it? How are the ways that people come to Leipzig to learn more? How would you recommend?
On the one hand, we have every day 4 to 10 visitors who observe our program. And as you said, every week, almost every week, there is a course about the things we do in cardiac surgery. And we also have this international meeting together with the group from Dallas. It's called Dallas, Leipzig, Leipzig, Dallas. Latest techniques, which will happen again in December, where we try to have the best surgeons from all over the world to introduce the new technologies and teach it to the young surgeons. And I think the visiting situation is very helpful. We have many surgeons coming from all over the world, from India, from China, and of course all from South America and the US. And some of them we keep. You know, if they are good, we put them into a fellowship program, and they stay with us and go back home and know how to do it.
Yes, I read that 1 in 5 German surgeons actually trained in Leipzig.
Well, that's almost true, yeah.
Yeah. Well, thank you very much for coming to talk to us. You've always got to have a life outside of surgery, and I've got one more final question. What's the best car, a British Jaguar E-Type or a German Mercedes McLaren?
Oh, no, you get it to the point. So I'm really, if it's a sunny day, I'm in a desperate situation. I'm colorblind.
All right.
So if I go through the countryside slowly, I take the Jaguar E-Type.
Yeah.
If I want to have fun, I take the Mercedes McLaren and go high speed.
Well, if you want me to drive the other one, I'm more than happy.
Okay.
Anyway, from
You're
myself,
welcome. Next time you come to Leipzig, so we can go together.
Well, that's on tape now, that is, so that's a deal. Well, from myself, Joel Dunning, and from everyone at CTSNet, I'd just like to say it's been an absolute pleasure. Thank you very much.
Oh, thank you for inviting me for this interview. Thank you so much.